Hello again. In the first part of the lecture, we were reviewing some concepts related with sensitivity and specificity as measures of validity of screening tests. So let's move on with what the sensitivity tells us. Sensitivity is a measure of the proportion of people with the disease who have a positive test result. So, for example, a test with 84% sensitivity means that the test identifies 84 out of 100 people with the disease. Specificity is a measure of the proportion of people without the disease who have a negative test result. So, for example, a test with 75% specificity will be negative in 75 out of 100 people without the disease. Let's see an example. This 2x2 table shows the results of a new rapid test to screen for influenza. There were 61 children who had influenza, and the rapid test was positive in 27 of them. There were 96 children who did not have influenza, and the rapid test was negative in 93 of them. So with these numbers, we can calculate sensitivity and specificity, and we can see that in this particular case, the sensitivity was 44% and specificity was 97%. Better specificity than sensitivity. Sensitivity indicates the proportion of people who truly have a designated disease who are so identified by the test. Sensitive tests have few false negatives. When a highly sensitive test is negative, it effectively rules out the diagnosis of disease. Specificity, on the other hand, indicates the proportion of people who are truly free of a disease who are so identified by the test. Specific tests have few false positives, and when a test is highly specific, a positive result can rule in the diagnosis. What can you do with this information about sensitivity and specificity to assess the value of a screening test? In the first place, you want high sensitivity because you don't want to miss cases. Later, you might look for a test with high specificity to sort out false positives from the true positives. Sensitivity and specificity are influenced by the cutoff point that we select to determine positive results. We will use three different scenarios to illustrate the changes that occur in sensitivity and specificity with resultant changes in the proportion of false negative and false positives depending on the cutoff point that we choose. If we set the cutoff point at A, the resulting test is highly sensitive. However, the specificity is lower. There are no false negatives, but there is a large number of false positive test results. We will have high sensitivity and low specificity. This test might be useful as a screening test for a disease where the cost of a false negative result is high. Now let's set the cutoff at point B. The result would be a test with equal sensitivity and specificity, as well as the same number of false positives and false negatives. We will have moderate sensitivity and moderate specificity. However, the usefulness of a screening test with these characteristics is highly questionable. Now, let's set the cutoff at point C. This cutoff leads to an insensitive test where specificity is extremely high. This type of test would be useful in situations where the cost of a false positive is high. Now let's review two concepts that describe the feasibility of a screening test: positive and negative predictive values. A positive predictive value indicates the proportion of people with a positive test who actually have the disease. In real life situation, we do the new test first and we don't have the results of a gold standard available. We want to know how this new test is doing. So the positive predictive value tells us about this. How many of test positives are true positives, and if this number is higher, as close to 100 as possible, then it suggests that this new test is doing as good as the gold standard. A negative predictive value indicates the proportion of people with a negative test who do not have the disease. Negative predictive value tell us how many of test negatives are true negatives, and if the number is high, it suggests that the new test is doing as good as the gold standard to rule out the disease. Back to our influenza testing example. There were 30 positive results, and 27 of them were in children who had influenza according to the gold standard. The predictive value of the test is 90%, indicating that 90% of children with a positive screening test truly have the disease. On the other hand, there were 127 negative results with the rapid test, and 93 of them were in children who did not have influenza by the gold standard. The negative predictive value of the test was 73%, indicating that 73% of children with a negative screening test truly do not have the disease. When evaluating the feasibility or success of a screening program, one should consider the positive and negative predictive values. A high positive predictive value implies that the program is effective because it detects a large proportion of actual cases among individuals with positive results. A low predictive value implies that resources are being wasted on diagnostic follow-ups of false positive results. There are some biases that can affect screening studies. In lead time bias, survival might appear longer among people that undergo screening because their detection was made earlier, not because they actually live longer. This type of bias overestimates the benefit of screening. Let's take a look at one example. In scenario a disease starts in 1985, is diagnosed in 1992, and the person dies of the disease because of the disease in 1995. Survival is 3 years after disease is detected. In diagram 2, we institute an effective screening program. The disease starts in 1985 and is detected by the screening program in 1989. The person dies of the disease in 1995. So how long was the survival based on this? It was 6 years. Screening seems to have increased the survival time of this person, right? You have noted that in either situation, it's 10 years from the time the disease started until the person dies. If our measure is survival time, we can easily have a lead time bias. In this example, there is actually no benefit of the screening process in terms of survival. The person still dies in 1995. The effect of the screening is to know about the disease for 3 years longer. That's it. So this example demonstrates a lead time bias of 3 years affecting screening of the disease. In length bias sampling, screening tends to identify cases with less aggressive forms of disease or cases with a long preclinical course, which usually means that the disease has a long clinical course and better survival. In our example, disease onset is set at 0 and each line represents an individual. The bottom person, for instance, has a very slow growth rate of a tumor, and in the top line with the steepest slope, it represents someone with aggressive disease. This person has a rapid growth of the tumor and dies. The individuals with slower tumor growth live to the point where they get screened. A screening initiative is more likely to detect slow-growing diseases. There is not much that a researcher can do about this type of bias other than to realize it's likely to occur. Volunteer bias is the systematic error from detecting disease in people who have a propensity to seek health care. If a screening study does not include a randomized process for selection, volunteers for a study or a screening are likely to be in better health than the general population. There are different ways to evaluate the effectiveness of a screening program, and using RCTs is a gold standard. Um, Initially, individuals would be randomized to be screened or not screened. Then there's a follow-up of the two study groups for the outcomes of interest. Remember that experimental studies of screening can only be performed when there is a state of clinical equipoise regarding screening effectiveness. This type of study designs for assessing screening requires large sample sizes and long follow-up periods. Cohort studies can be used to evaluate screening programs. In this case, participants decide themselves to be screened or not, and they are followed to ascertain the outcome of interest. As we know, this type of design is more susceptible to confounding and bias than RCTs, but in some circumstances they constitute a good way to avoid ethical dilemmas related with screening. Case control studies can also be used to assess screening programs. In this case, we select individuals with a recent disease or who have died from the disease targeted by the screening, and then controls are selected from the population that gave rise to the cases. Then we obtain information on screening status and potential confounders by interview or medical record review. The challenge with using case control studies for this purpose is to obtain accurate exposure information and controlling for confounding. Screening might have important effects on disease incidence. Prostate cancer is an example of this. This is the most common cancer among men, and it progresses slowly with the long clinical and preclinical phases. Prostate-specific antigen, or PSA, was first discovered in the 70s and approved in the 80s to monitor the incidence of cancer. PSA soon became a widely screening tool in the United States for asymptomatic men. Following this, the incidence of prostate cancer skyrocketed. The figure from SEER data display this rapid increase. Prior to routine PSA testing, 1 in 10 men were diagnosed with prostate cancer. After the widespread PSA testing, 1 in 6 men were diagnosed with prostate cancer. Correspondingly, in the mid-90s, mortality due to prostate cancer began to decline at a rate of approximately 4% per year, as we can see in the graph. This might have been due to an increase in PSA screening. However, some have suggested that this is due to earlier and increasingly aggressive prostate cancer treatments beginning around the same time period. In this session, we saw how surveillance is a critical public health tool that helps to guide prevention and treatment programs. We also reviewed the principles for choosing an appropriate screening test and some measures of validity and feasibility of screening tests. Important consideration was given to choosing an appropriate cutoff value to decide which screening test to use. Finally, we review some bias related to screening evaluation and how we can use different types of study designs to answer questions about screening. Remember to complete the weekly trivia, participate in the weekly forum, and complete the case study exercise.